Hi, I'm Dr. David Rubin. I'm a professor of medicine at the University of Chicago Medicine, and welcome to Best of the Day at the Advances in IBD meeting in Hollywood, Florida. This is the national meeting of the Crohn's and Colitis Foundation of America, and this meeting is running from December 12th through the 14th. I'm really pleased today that I'm here with my partner and colleague and friend, Professor and Dr. Stephen Hanauer from the University of Chicago. Welcome, Steve.
Thank you, David.
Dr. Hanauer is also the co-director of this meeting, so we're delighted that he's here, and this is his 8th year directing this really popular and growing meeting. So before we get into actually the clinical elements of the meeting, we should just update those who are watching at home that the meeting next year will actually be in Orlando, Florida, and I think that's because it's been growing and...
We have over 2,000 attendants this year. The meeting continues to grow, and we're incredibly enthusiastic.
Well, congratulations. It's really amazing.
Thank you.
And good for our patients.
Absolutely.
Yeah. So we're going to talk today a little bit about the clinical themes of the meeting and some of the emerging areas that are of importance. What stands out to you as one of the first topics?
Well, I think one of the first topics is that this is an exciting year. We've had 2 new drugs approved for ulcerative colitis over the past year, and we have a drug that is about to be approved, vedolizumab, that was recently evaluated at the FDA, and we would anticipate a launch sometime in the middle of 2014.
That's great. And what can patients expect from some of these new therapies?
Well, I think there are a number of different aspects that they can expect. And if we just take one at a time, budesonide in an MMX formulation. We know that budesonide has been effective in ileal and right-sided colonic Crohn's disease. It has effects that are almost as potent as steroids, without the systemic side effects of prednisone, for example. The problem is it's relatively limited in its extent of engagement, the ileum and right colon, and so it's been approved for Crohn's disease. We now have a non-systemic form of budesonide in the MMX delivery system that releases through the colon, and as a first-line therapy for patients with mild to moderate disease, this has been effective. The problem is that we really don't know where to position it as yet. I don't think that budesonide is really going to overcome mesalamine in the majority of patients. It's too much of mesalamine's been too much of a foundational agent. But that it's been tested in that situation. Where do I think it'll be practical? I think it'll be more practical on top of mesalamine to prevent the need for systemic steroids, and I think you're engaged in one of the trials to look at that situation.
Yeah.
And in the future, we may have a foam preparation of budesonide like they have in Europe. So I think that it is a way of steroid sparing to a degree, and frankly, we've seen the same analogy in asthma. In asthma, we've moved from systemic steroids, which had a lot of side effects, to non-systemic steroids as inhalers, and even in allergic rhinitis, have become the standard of care. So I think it will give us another tool in our armamentarium, mainly for mild to moderate disease.
We know that our colleagues who treat mild to moderate ulcerative colitis often will prescribe a 5-ASA with prednisone, a systemic corticosteroid. Can you give us some guidance? Do you recommend that they start with the 5-ASA and then move to the non-systemic delivery system with the budesonide, or what do you give people in terms of guidance and how to use this?
Well, there's several practicalities to this. The first is that we don't have any maintenance data with the MMX budesonide. Those studies are in progress. But we can make some extrapolations or assumptions from what we've seen with the ileal release formulation. The other problem is that the MMX only comes in one dosage form, 9 milligrams. So we don't have the ability to taper as we do with the ileal release in the setting of ulcerative colitis, except I think the practicality will be to go to every other day as a form of eventual tapering. As I said, I don't think people are going to use it instead of mesalamine up front, probably on top of it.
Right. So let's move on to a different class. We now have 3 anti-TNFs available in ulcerative colitis. We can stick with the ulcerative colitis theme for now. Tell us a little bit about what our options are and how we should be thinking about that.
Well, already infliximab and adalimumab have been approved in ulcerative colitis. Both are approved in the moderate to severe ulcerative colitis in an outpatient population. And we've had recent data over the past couple of years of intravenous infliximab, even in the severe hospitalized patient, where it's pretty much taken over for cyclosporine in that population. Golimumab is another subcutaneous or parenteral form of an anti-TNF. It has the same kind of human structure that adalimumab does, slightly modified. It's been tested in the same population that we've seen infliximab and adalimumab tested in the moderate to severe outpatient population. So it has very similar results to the other two. Of course, we can't compare them head to head. We don't have those comparative effectiveness studies yet, but it looks pretty similar to both of them. There are a couple little things we've learned, additional things we've learned about golimumab. In the studies, and these were done prospectively, we also found that that serum levels do impact on effectiveness. In the group of patients who have the higher serum levels, we see more effectiveness of this. Now, whether that's due, the chicken and the egg hasn't really been established. We know patients who have severe disease lose the antibodies into their feces, and they have a more rapid clearance. So that may account for a lower level. On the other hand, it's intuitive that if we can push up the levels and inhibit TNF more completely, that we're going to get some benefits from it. So I think golimumab does give us another alternative. It can be first or second anti-TNF. The immunogenicity to one agent does not transfer to the other, so if we have antibodies to any of these, we can switch around between them.
I think that those are very important points, and the idea of which drug to start with, I think, remains a bit confusing to many of our colleagues, and it ultimately comes down to discussions with patients about the differences between therapies as well as what payers will allow. We've been studying, as you know, at U of C, looking at some of the fecal levels and trying to get a handle on this, because we don't quite know yet what to do if the patient's not responding. Is it really that this mechanism is failing in that patient population, or is it just that they're not getting enough exposure to therapy because it's just leaking right out into the toilet?
Well, I agree, and there are other markers for that. We know that patients who have severe colitis with deep ulcers have a worse prognosis, probably because they have increased clearance through the fecal losses. And a really good marker for that is low albumin. Mm-hmm. In the patients who have low albumin, they're probably going to be needing redosing. And as you and I have followed our inpatients, we often see patients who respond briefly to an infusion of infliximab and then they lose their response. And I think we've tended to increase the dose to 10 milligrams in those patients and often try to redose them if they have a transient response.
I think a lot of our colleagues are doing the same thing. We need a little bit more data to guide us. And you made a passing comment that cyclosporine has been sort of put to the side by a lot of people. But perhaps a therapy like that that's not protein-based still has a role. So I know we've been using it, but why don't you tell our colleagues a little bit more about where you think that fits?
Well, within the spectrum of bad severe colitis, we have severe disease, but we also have fulminant. And I think that the patients who present with low albumin and the really sick patients, markedly elevated C-reactive protein, they may respond better to cyclosporine. Now that wasn't seen in the CYCIF study in Europe because they have different means and different indications for hospitalization. I think many of the patients that they hospitalized, we'd be treating as outpatients.
That's a good.
So I think that reflects it. The other thing is we give continuous infusions of cyclosporine and monitor blood levels. So we are treating to a blood level in that situation, and that may account for some of our impressions that cyclosporine may be more effective than infliximab in the really severe or fulminant cases.
I think that's a valuable point. So why don't we talk about the last class that's emerging in ulcerative colitis, and we can bridge that right into Crohn's since it's looking at both disease states. Vedolizumab, so a leukocyte trafficking inhibitor. Tell us a little bit about that and where it may fit in our future treatment strategies.
Well, there's really a good logical progression. We have animal model data that inhibiting lymphocyte trafficking will improve the disease in the cotton top tamarin. We have data in Crohn's disease with natalizumab that the inhibition of the alpha-4 integrin, which is ubiquitous throughout the body, is effective in Crohn's disease. But of course, our utility of that is limited by the risk of progressive multifocal leukoencephalopathy. And it's interesting that natalizumab hasn't really been studied to any degree in ulcerative colitis yet. But the original studies did show that it is an effective induction agent, maybe a slightly longer onset of action, but we see the real benefits, the biggest benefits, I should say, in maintenance therapy. Vedolizumab is somewhat different. It's an integrin inhibitor, but it inhibits the alpha-4 beta-7 integrin that is limited to the gut. And so it is more specific, we believe, towards the gut. And we have a lot of evidence for that. We don't see changes in lymphocyte populations, for instance, in the brain with vedolizumab that we do see with natalizumab. So we think it will be more enteric specific. And there have been 2 large clinical trials done, one in ulcerative colitis and one in Crohn's disease. And as you well know, just had an FDA advisory hearing earlier this week that came out with very positive results. In ulcerative colitis, vedolizumab has very impressive benefits. Perhaps a little bit slower in onset for a complete reaction, but still very good onset of action and an excellent maintenance profile. And the big thing about vedolizumab, as far as it has good clinical impact, but we saw very little side effects. In particular, the infectious complications were quite minimal, primarily limited to nasopharyngitis, upper respiratory tract infections. But we didn't see other serious opportunistic infections as we see with the anti-TNFs.
So it's good news for our patients with ulcerative colitis, a different mechanism of action and what looks to be a very stable therapy when that becomes available.
Yes, I think the big question is going to be positioning. And we've seen this with the introduction of the anti-TNFs. The study population has been a really difficult population. The FDA has restricted these early developments to patients who are not responding to steroids, immunosuppressives, and even anti-TNF agents. So we have seen studies in ulcerative colitis with vedolizumab demonstrating benefits in all of those populations, including the patients who had not responded or lost response to anti-TNFs.
So the advisory committee meeting by the FDA this past Monday looked like they were going to allow it to be earlier, but we'll have to see how the final labeling looks.
Yeah, I think the committee members may be a little bit more enthusiastic than the FDA. I suspect, as we've seen in the past, what we see the patient population studied in the clinical trials are going to reflect what their indications are going to be.
Although, like many of the previous therapies, when patients are treated who are naive to a class of therapy, they tend to respond better to the newer drug. So hopefully someone will recognize that along the way.
Well, my personal belief is that we are treating too late with the biologics. We have great evidence in rheumatoid arthritis that if you treat the disease early, before there is structural damage in rheumatoid arthritis, it looks like a totally different therapy. It's highly effective, it prevents structural damage, and the side effect profile, when you take away the steroids and when you take away the immunosuppressives, these drugs look much more effective and at really low risk.
So that's a perfect segue to Crohn's disease, because we think of Crohn's as having maybe more than ulcerative colitis, this timing issue. So let's talk about Crohn's now.
So vedolizumab was also studied in Crohn's. Here we didn't see as substantial effects in induction, particularly early on. And a second trial looking at a later phase, at 10 weeks rather than 6 or 8, did show some benefits. It wasn't resounding, but we saw those benefits continue to accrue, and again, primarily as maintenance therapy. And we're beginning to make sense of this. With vedolizumab, we're preventing lymphocytes from going into the tissue. But in Crohn's disease, there's a mass of lymphocytes that are already present. And that's not affected by vedolizumab. So we have to wait perhaps for those lymphocytes to be destroyed or apoptose, and then new ones won't come in. So this, I think, begins to explain why it may have a better maintenance benefit, particularly in that population. That Crohn's population that was studied with vedolizumab were really refractory, severe disease for the most part, and tough cases.
That's actually what I told the FDA when I had the opportunity to speak, was that actually, although not statistically different, numerically, the patients in the vedo arms of the Crohn's studies had longer duration of disease and had more surgeries. So there was a really tough population, as we know, in all these trials.
Absolutely.
So let's talk more about Crohn's, though. What else is happening in the field? What other new therapies might be coming? And how should our colleagues be adjusting their treatment strategies?
Okay, so over the past year, there have been two large population studies done in Europe, one in France, one in Spain, that looked at early intervention with azathioprine. And we've seen in studies in adults and in children, particularly in the Markowitz study in kids, that patients induced with steroids and then switched over to treated concomitantly and then maintained on 6-mercaptopurine had a remarkable long-term benefit. So there's this concept that treating early with azathioprine may have benefits. These two trials looked at that population. They looked at adults with bad prognoses and treated with azathioprine from the very onset. They didn't show much benefit of azathioprine. The Spanish study actually showed a little bit of benefit in steroid sparing, but overall they were unimpressive. And while Bill Sanborn thinks that monotherapy with azathioprine is not very effective and perhaps risky long term, I don't think the current studies really reflected what was done or my utility of this. I see azathioprine as a maintenance therapy after steroid-induced remission. Mm-hmm. And actually we see this with some studies in ulcerative colitis that used methotrexate. When patients, in the COMMIT study in ulcerative colitis, when patients were induced with steroids and then switched over to infliximab with or without methotrexate, there wasn't much of a difference because the patients were actually induced with steroids. And so I look at azathioprine as a maintenance therapy after steroid induction. And of course there are other utilities as combination therapy with biologics to reduce immunogenicity.
So in the past, I know you've studied the use of metabolites of the thiopurines to guide management. Do you think that plays a role in interpreting these new studies that suggest that therapies don't work as well?
Possibly, but I think it was really the positioning. But as you and I have discussed for a long time, this concept of giving these agents that have a genetic polymorphism in the enzyme that metabolizes it in a milligram per kilogram basis really doesn't make much sense to me.
And you pioneered the use of allopurinol with the thiopurine, so does that add something to interpreting all this? Is there still a role for trying to optimize it that way?
Well, we certainly believe there's a role in patients who have been optimized according to thioguanine levels. However that's accomplished, we see benefits in those populations.
So you commented that in general we've been treating with biological therapies too late. Can you teach our colleagues who are watching this what we're trying to get to? I mean, how do you know when you should be treating earlier? Who's the patient that we're missing in general?
I think that, first of all, we do need trials in early Crohn's disease. Now, the problem becomes how one defines early disease. If you define it by months after diagnosis, within 18 months, even a large proportion of that population already has structural damage. So I think early Crohn's disease should be defined as before there's evidence of structural damage. We can predict the evolution by a number of factors. Deep ulcerations in Crohn's disease, patients who are cigarette smokers, those who have more extensive disease or who already present with structural damage, but that doesn't really help us. Mm-hmm. So I think if we can treat patients early by bad prognosis and importantly, if they don't yet have significant structural damage, that I think would be an optimal population.
So the logical group is the post-op patient, right? Somebody who's had a limited resection with a primary anastomosis. Then we know they're likely to have recurrence of some degree, and we're starting over. So how do we know when we should be using a biological therapy in that patient?
Well, we have the interesting preliminary data from Pittsburgh that looks very resounding, and there's supportive data from around the world that's less controlled, that giving the anti-TNFs, either infliximab or adalimumab to this point, can prevent the postoperative recurrence. Now, should we be giving it to everybody? Well, first of all, we're waiting for the large clinical trial to be completed, and we expect within the year we'll have results from a much larger trial with infliximab. At the moment, we're selecting patients at the biggest risk for recurrence. Those who've had rapid progression of disease, again, patients who've had significant transmural complications, smokers who should first and foremost stop smoking. Those are the patients at the biggest risk of recurrence, and those that we are directing therapy. And of course, patients who've been on anti-T, who have needed it before, are patients who we're tending to give anti-TNF therapy after surgical resections.
Now, during Bill Sanborn's presentation yesterday, he also spoke about ustekinumab and talked a little bit about other therapies that are in the pipeline. Do you want to comment on any of those?
Well, there are numerous therapies in the pipeline. I think the closest ones to completion of their phase 3 studies and then evaluation of those are ustekinumab, which of course is already approved and is a dramatic drug for improvement in psoriasis and psoriatic arthritis, has been studied in phase 2 studies, and interestingly initially looked more beneficial in patients who had not responded to anti-TNFs. Now that's going to be looked at more extensively in the phase 3 studies. Personally, I'm very cautious of accepting phase 2 data as being ultimate. We've seen many, many drugs pass away in phase 3. But it looks like the mechanism makes sense from the genetic pathways that have identified the IL-12/23 pathway in these immune-mediated diseases. So it makes sense. We need to clarify the dose. You know, just giving the psoriatic dose to patients is unlikely to be as effective in Crohn's disease.
Sure.
We've seen that with all the other agents. With the anti-TNFs, we need higher doses. So we need to be, we really need to interpret the dose in those studies and the dose ranging. And the other drug that's being studied now in phase 3 is tofacitinib. That's also recently approved for rheumatoid arthritis, is a JAK kinase inhibitor. It really is a potent immune inhibitor. It works directly on NF-kappa beta, so it has a lot of downstream effects. It looks to be effective in the phase 2 studies. I think with this drug, the issue is going to be the dose and the side effects. We may need higher doses in IBD and in particularly Crohn's, and that's going to border on some of the potential toxicities of this drug. So again, we need to wait for the phase 3 studies and really see the dose effect and the toxicity at optimal dosing.
So the very last topic, and this will be brief, but it's very important, is that you're really a master at explaining risks and benefits to patients. There's this appreciation, maybe more so now, but it shouldn't have been ignored previously, of a shared decision-making model in how we manage our patients. Understanding risks and concerns about risks and the benefits of all these different therapeutic options. Do you have any advice for our colleagues about how to think about that?
Well, I think, you know, our friend and colleague Corey Siegel is really leading the way with this. We've always, you and I, and by our mentor, Dr. Kersner, have shared decisions with our patients. It means explaining the situation in common terms, not using statistical methodologies, and really coming down to earth with patients. So for instance, the concept of lymphoma. We've seen that statistically in about 1 in 400 patients. But that doesn't really give the patients the perspective that the risk of dying in a car accident is 1 in 250. So there are many different tools that we can use, including a plot of the 1,000 patients that Corey has exemplified, to really put that risk in perspective, but also the benefit. Frankly, I think the cost of therapies biases the concept of the risk. You know, particularly for the anti-TNFs, these are really the safest drugs that have ever been introduced, and they're far safer than steroids for treatment. But the cost pushes us to the consideration of risk. And the other thing is that all risks aren't looked at the same way by patients. So as we know, the risk of developing progressive multifocal leukoencephalopathy may be 1 in 1,000 in patients, but patients don't want to get that kind of disease. They're very much afraid of a disease that's going to affect their brain, and that's going to bias them. You know, that risk applied to the risk of cancer may be very different.
I think that's correct. And for a patient, and for some patients, they're going to be the one. They can't necessarily interpret it because it's them. And the other part that I always talk about is the shifting risk-benefit ratio. In other words, when the patient is on a therapy and they have benefit, their perception of risk actually changes. So what I've been explaining to my colleagues has been the concept of take baby steps. You know, agree that they need to feel better and we want to use a therapy that's effective. And yes, we acknowledge risk and let's discuss it, but then let's reevaluate that risk in the context of whether the therapy is working, because it changes.
Absolutely. When patients are really sick and not responding, they're willing to take more risk. As they get better, then they see it in a very different perspective, as you mentioned.
Well, I want to thank you for sharing all your insight today, and congratulations again on a really successful meeting, and we'll see you in Orlando next year.
Absolutely.
I'll see you in Chicago. This has been Best of the Day at the Advances in IBD meeting. I've been with Professor and Dr. Stephen Hanauer from the University of Chicago Medicine. Thanks for joining us.